Next, I would like to invite Dr. Hernando Garzon to do his presentation on organizing accident and emergency for a disaster.
Thank you very much. And I've been asked to spend a little bit of time talking about how you can organize your accident and emergency department for a disaster. So we'll spend the next 45 minutes or so discussing that. And I think for most people in Sri Lanka, you probably don't need to be reminded of the importance of why we need to be better prepared or as prepared as we can be for disaster situations. Anyone who remembers, actually there's probably many people in the audience who were young enough and perhaps not by the coast that you may not remember or lived through the tsunami in 2004, 2005, but certainly that was a very big event that struck this country, and certainly with all the civil unrest that has occurred, there are areas of this country that have been under sort of chronic disasters too for some time. So I think everyone in this audience appreciates how this can affect communities and populations. I have for those of you who need a little more convincing, I have a 27-second video to show you that hopefully will frame the whole discussion we have for the next 45 minutes. And it's a video that was taken by a staff member from Doctors Without Borders in a Pakistani emergency department, a Pakistani hospital, when multiple trauma victims were brought to the hospital. And so I'll show you the video, and then we can go through and discuss it and discuss emergency preparedness or disaster preparedness. So for most of us who work in accident and emergency departments, that's not a normal day. For some it is, perhaps. But I think there are a number of things that I'd like to point out about that. And I think one of the things that's common in disasters, especially initially, is that there's a tremendous amount of chaos. Right? There's shouting, there's inadequate or inaccurate information. You don't know where things are, that kind of thing. And there's a lot of things we can do to try and bring order to that chaos. As a matter of fact, when I speak about emergency management and disaster response, I frequently say that the common theme of anything you do in a disaster situation is to try and bring order to the chaos little by little. And at the beginning, things are very crazy and chaotic, and as the response goes along, things come under a little bit better control. But you can see there are many things in that short video that illustrate the importance of adequate preparedness. There were victims on the floor in multiple rooms. There were all sorts of people in that video, and you don't know who is who. Who's the medical staff? Who are family and friends? We don't even know if these were combatants, and maybe some of the people are their allies, but maybe some of the people are in there were out to finish the job that they started, if it was civil unrest. So there was no crowd control or security in the process, and there was no orderly way to manage these patients. So I'll go through that, and I'll come back to this video as we discuss some of the key points of preparedness. So the overview for this lecture I want to talk about here is, you see the accident and emergency preparedness is at the bottom of this list, because I think even though we'll spend most of our time focusing on those details of how you can do this in your accident and emergency department, there are several key concepts or larger issues that we should discuss first so you're aware of the importance or the significance of the detailed plans you make in your department. First is to discuss the cycle of planning, mitigation, response, and recovery, and how that applies to the whole issue or the whole area of emergency management and disaster planning. Then I'll discuss some general concepts of emergency management and disaster planning. And those two things are actually the same thing. We used to use the term in the United States disaster preparedness, disaster planning, but we've more recently been using the term emergency management because sometimes you'll get a surge of patients from a bus accident that isn't necessarily a full-fledged disaster, but it requires you to implement your emergency plan and surge up and get additional staff and open other ORs and call in other staff and those kinds of things. So but we actually all now are grouping that and discussing it as emergency management. So if I say emergency management, I also mean disaster preparedness. I'm talking about the same thing. And emergency management really happens not just in healthcare, not just at our individual hospitals, but it really should and can happen in every sector of society. Civic organizations, critical infrastructure things, right? Our power companies, our police and fire departments, our law enforcement needs to be involved with that kind of thing. Governmental organizations and entities, and it's an international process as well. And I'll go through that a little bit. Then I'll discuss more specifically healthcare emergency management, and then I'll finish talking about the issues in the accident and emergency department. So one of the first concepts that I would like to get across is this idea that we sort of live in a cycle in the disaster management process. And over on the right side of the slide, you see this event thing, and that's a disaster event. So when a disaster happens, we go into what's called a response mode. And that's when we activate all our emergency plans and put them in place to be able to respond adequately. And for most disasters, that's actually a short-lived period of time. That could be a couple hours, a few days, maybe a few weeks. The one exception might be something like a pandemic flu. Pandemic flus usually scale up gradually and can last for many months before they abate and slow down. But most other kinds of disasters, you have an immediate need to activate, and they can last, as I said, just for hours or days or even a few weeks. And that's a few weeks tends to be a long time or a very big disaster. After the response phase, we move into recovery, mitigation, and preparation or preparedness. Recovery is the process of sort of cleaning up, restocking, doing definitive surgeries on people that initially had just stabilizing surgeries to get through the load of victims, those kinds of things. So the recovery process follows the response process, and it's not just in healthcare, right? In other sectors, that's when we rebuild houses and move people back to the communities that were affected by disasters. That's when power plants restore not just the electricity to the critical sites, but restore power to everything that had power before, those kinds of things. That's the recovery phase. After recovery, we also get involved with mitigation. And so mitigation is undertaking activities or programs that either decrease or prevent the problems we see in disasters. So, for example, in earthquake-prone countries or communities, we will build with different engineering codes that make buildings more resistant to earthquakes. We do that in California. They do that in Chile and Argentina, all around the world where there are enough resources to be able to do that. That's a mitigation activity, for example. One thing we've done in many hospitals in the United States that are in flood-prone areas, that after New Orleans and Louisiana, the area that we live, Sacramento is the second most likely city to flood in the United States. And after our experience with Hurricane Katrina and the flooding in New Orleans and having to evacuate that city, we evaluated our healthcare system and its capacity to respond in Sacramento. And so one of the things that we've done is we moved all the emergency generators from ground level to a second level, or we've essentially built them up on stilts, because one of the things that happens in New Orleans is that all the hospitals were on emergency generator power because they'd lost the power from the utility company with the flooding, but then the hospitals flooded, their generators flooded because they were either on the first floor or in the basement, and now the hospitals were without power. So mitigation activity is learning from that lesson and putting your generators up in areas that are prone to flooding. That's examples of mitigation. And then the preparation phase is, as you'll see as we go through, is planning for what you're going to do in a disaster. What needs to get done? Do we need extra supplies? How are we going to get the additional staff to respond? If we need to evacuate the clinic or the facility or the hospital, how do we go about doing that? That's all the planning process. And so those are the 4 key stages in the cycle of disaster management or emergency management. There are a couple of points I'd like to make about that. If you look at this round circle, I'd actually like to shorten the response to just be a tiny little sliver. Because really, over time, the amount of time that we spend in the disaster response phase is really quite small. Disasters don't happen all that often, right? We really spend most of our time, what I'd like to do is enlarge this mitigation and preparation phase, because we spend most of our time in that phase, making the changes that we need to make us more resilient to disasters and preparing and planning to be in disasters. So that's one thing that is helpful to understand. The other one is I always teach that how we do during the response phase, how effective we are in responding to disasters, is totally determined by what we've done in the mitigation and preparation phase. Because if you get to the disaster point and you've done no planning and no preparation, of course it's not going to go well, like in that video. Chaos, who's in charge, where do we put these number of victims, that kind of thing. Whereas if you've planned and prepared and you've exercised your plan and you've trained all of your staff, then when the disaster happens, things proceed more orderly and you're able to deal with the problems that disasters give you. So what we do in preparation determines how effective our response is to disaster. So at the international level, there's a lot of attention to this and there are a lot of resources. I just list a couple of them here. The Interagency Standing Committee is a multi-agency committee made up of the United Nations, the World Health Organization, and many others. And they produce a number of very helpful documents, including this one that's on the slide here. Preparedness saves time, money, and lives. As we just heard in the previous lecture, having a trauma care system will save lives, will decrease the cost to the community. Same thing with this. Adequate disaster preparedness will really save money and lives when the next disaster strikes. So the WHO, the World Health Organization, has many resources. The International Committee for the Red Cross does. And there are national guidelines. There are some that I've looked on the websites for the government agencies in Sri Lanka. There are some beginning policies around disaster preparedness that the government undertakes as well. So you have to understand that this emergency management occurs at an international level as well. The other important thing is that probably 10 to 15 years ago, the international model for emergency management was focused on the relief teams that came in from outside to help low-resource communities in poor countries deal with disasters. So they would focus on relief teams from richer countries, Japan, Europe, Canada, U.S. They would put resources into that. They would bring trained people from the United Nations. They would bring in the food supplies and relief supplies from outside. And what they've discovered is that's really not enough, that it takes time to get those resources into the country. It can take days just to see the first few teams, and it can take a week or more to get a full-scale international response into a country to help out. So really over the last 10 years, the WHO and the Red Cross and the UN have really focused on building the emergency management capacity of even low and middle income countries. Because there are, just like I spoke about yesterday, there are inexpensive changes that you can make to an EMS, to create an EMS system. There are also inexpensive changes and things that can be done in low and middle income countries to make them more self-sufficient and better prepared to respond themselves. So for big disasters, we still need the international community to come in and help. But if you have local community and national preparedness, you're going to save lives and you're going to make a lot of difference from the moment the disaster strike until the additional assistance arrives from the international resources. So a couple more examples of what's available online. If you look up, if you search disaster management, emergency management on the International Red Cross site, the WHO website, you'll get all of this information. This information is really quite available and helpful. The one on the left is from the International Committee for the Red Cross. The one on the right is one of the many documents that's available on the World Health Organization website. So let me talk about some of the concepts in emergency management. And I think first and foremost, it's a complex process. And I'll just mention some of the words some of the key phrases that we talk about, some of the areas that work exists. And I'm discussing this emergency management, at least on this slide, at a national level or community level. And we'll discuss a little bit about how that goes into healthcare as well. So one of the first things that any community, country, health facility has to do is do some risk management or risk assessment, right? What are the things that we're most prone or vulnerable to? So here in Sri Lanka, you don't necessarily need to do a lot of earthquake planning, for example, or you don't need to do much planning for cold weather situations. You know, you're not going to have such a freeze that the water pipes break and flood. But there are many things that you can do around other kinds of disasters that you may be exposed to. There's other weather events, obviously, tsunamis, typhoons, other things that can affect this area. So your community, your health facility needs to do a risk assessment. In healthcare, we call that a hazard vulnerability assessment. What are the hazards that our healthcare system, our healthcare facility is vulnerable to, and how do we prepare for that? The other thing that's commonly discussed in emergency management is coordination. And again, as you've heard in many levels around trauma care, certainly also with disaster preparedness, coordination is very important because we don't work in a silo in a disaster. All different aspects of our community and society get involved. So for a healthcare facility, you have to coordinate with the pre-hospital care system. You have to coordinate with civic organizations. You have to know what the government response is. Where do I get information or communication about the disaster? Where is it safe to send patients and families after they've been treated? There's all sorts of interaction and coordination that needs to happen with other partners in the response. The other concept that's discussed in emergency management is the community resilience, as I mentioned. The better our communities are prepared to take care of themselves in disasters, the more people will survive and the more effective the whole response will be at the national level, at the community level, and at the local individual level and the healthcare level. Information management is important. How is information about an event distributed? How do we get information out about where people can go for food, water, or shelter, or medical resources when events happen? So what is the communication process that happens, and how is our healthcare system integrated into that? How can we get information about the number of victims that may be coming to us in an event, or how can we get information to the officials about what we're doing in the healthcare system and to get medications and supplies and additional personnel to help in the response. Or early warning systems are important for things like predictable natural disasters. So like one of the reasons that the tsunami was so devastating is that many communities didn't know it was coming, even though the earthquake had happened sometimes hours before, and that the monitoring agencies in other parts of the world were concerned about a tsunami wave happened, but rural communities had no notification system to let them know something was on the way. So for something like a tsunami warning system, for example, or other weather events like hurricanes in the Atlantic or typhoons in the Pacific, if there's a warning system for communities, people can get notified, and the impact of that disaster will be less, at least in terms of the loss of human life. Resource mobilization. How do we stock up on items that we may need during disasters? And this isn't just in healthcare, for example. At a personal level, one of the things I teach and train in the United States is personal disaster preparedness. How do you stock up additional supplies of potable water and food for your family, for example, if you had to exist independently for 2 weeks? How do you prepare yourself and how do you manage your resources at an individual level, at the place you work, in healthcare, for example, or in a community? And then the last thing frequently that's really important around emergency management is public education and training on all of these topics. And frequently that can happen through civic organizations. It can happen through schools. It can happen through the Red Cross. It can happen through Rotary Club. It can happen through many religious organizations and things like that. So let me talk a little bit about healthcare emergency management and these topics that I've been talking about that function at a national and international level. We can certainly apply also in healthcare. So first and foremost, whether you work in a small clinic facility or individual office, or whether you work in a large tertiary care medical center like this, you really need to designate a responsible person. Who is the person in charge at that facility for emergency management or disaster management activities? Because you need some accountability. If there's not a person in charge for this or responsible for this area, it tends to sort of sit and not get done. I think it's sort of human nature. One of the struggles we have in emergency management is people think, oh, it's not going to happen to us, or at least it's not going to happen to us today. There's more important things I have to do in my personal life or in my work life. This is something I can take care of later, kind of thing. And so very frequently, everywhere in the world, whether it's a developing nation or a poor nation, disaster management, disaster preparedness gets left to be done later on. So if you assign responsibility and appoint a leader for disaster management, that's one of the first steps that makes things progress and get things done more often. The next thing you have to do is really create a disaster preparedness committee. And we'll talk about the specifics of that. But again, because it is a multidisciplinary process, you need representation from different areas of your medical center. Even if you're in a small clinic, if you have a staff of 6 or 8 people and you run a clinic, it's really worthwhile to get everyone's input and create an emergency response plan or disaster plan for your small clinic. How are you going to get people into work? How are you going to notify them that something's happened? If maybe you decide to close down your clinic and then your staff can go help in the hospital or some other nearby facility. So even a small clinic will benefit from having some type of disaster plan. Once you get that team together, then you can go about the activities of doing the hazard vulnerability assessment. And once you have that, you can make your disaster plan, or as we call it in the United States, an emergency operation plan, an EOP. And then the last important thing about this whole process in healthcare is actually practicing your plan and doing disaster drills. Talk about that. So as far as the committee is concerned, again, because it's multidisciplinary, you really need representation from different areas. You need not just the medical expertise from the emergency or accident and emergency department, but also the surgeons, the nursing staff, the security staff, radiology, blood bank, basically any system in your hospital that is affected or has to do some work in a disaster response should have some representation in the disaster committee. In the United States, it's a requirement of any hospital, but we have a joint commission which approves and certifies hospitals and does reviews every 2 to 3 years. And they always look at the emergency management process at every hospital. You have to appoint a leader. You have to have a committee. They look at the minutes of the meetings. Most committees meet at least quarterly. Many of them meet monthly. So if you're doing this work on a regular basis, you can move your plans forward. As far as the hazard vulnerability assessment, again, emergency managers are used to doing this. There are existing tools for how you can do this. There's templates. There's questionnaires that you fill out so you can identify what are the likely hazards in your area. Are you in an agricultural area? Are you in an industrial area? Are you susceptible to chemical spills? Are you in an earthquake area? All these things that help you determine what your hazards are for your particular facility. Once you've determined those, and we actually revisit those every year in hospitals in the U.S. Because things can change, obviously, or other events happen that show us, oh no, we're actually more vulnerable for this kind of thing than for that kind of thing. So those can adjust year to year, but in general they stay the same. And then you take those HVAs, those assessments, and then you build your emergency operation plan based on that. But you also build your emergency plan, and the common phrase, and this is used internationally as well, is to have an all hazards approach. So even though we may have really detailed plans for earthquake response in California, for example, or wildland fires. We have a lot of those in California as well, that we also have this all hazards approach that in case we get a train derailment or a terrorist event or those kinds of other things, we can also be prepared for whatever kind of disaster or emergency comes along. So let me talk a little bit about the emergency operation plan for healthcare for any facility. It's really a playbook or a guide for how you operate in a disaster. So it's the kind of thing that once you prepare the plan, it becomes a guidebook for what you're going to do during a disaster. The important thing to do is to keep revisiting that plan and training on that plan, because what I've seen happen is once it's done, you pat yourself on the back about the great job you did, and then you put it on the shelf and it gathers dust. And 2 years go by and the disaster comes along and people are like in that video where there's chaos, they don't know what they're doing. Someone says, I think we have an emergency plan, where is it? It takes them 20 minutes to find it and pull it off the shelf. And by that time, they're going through it saying, I'm not really familiar with what's in here. It's been 2 years since I looked at this. So it's important to not only create a plan, but also to have it be a living, breathing plan that you exercise and look at and review and edit along the way. For a small clinic, you may just have one emergency operation plan that addresses all the important things for you to do. For a large facility like this, a big hospital, you want probably a main facility plan, but the key departments probably need their own plan that's complementary. So the accident and emergency department may have its own plan that's specific to operations there. The operating theater, the surgery department may have their own kind of plan that addresses the issues that they're going to face in a disaster and so on. Usually you organize this by sections, and I'll go through the sections. Online. I think the screen here is gone, but I think I can go on with what's on the screen there. And one of the other key features of emergency operation plans is to have job action sheets for each position. So job action sheet is literally a 1 or 2 page piece of paper, and for every key position in your emergency operation plan, it has exactly what you need to do, so that if someone is assigned to say you're going to be the leader of the triage unit, and that nurse or that doctor isn't familiar with the job or hasn't done it in a couple of months, that job action sheet is really a bullet point of what they're responsible for and what they need to accomplish in that role. So it could be very helpful when the disaster strikes to pull out these job action sheets and give them to the people that are in each position. And the other thing that can be in your emergency operation plan, or should be, are protocols or procedures to follow in certain ways, and we'll discuss what some of those can be. So key elements of your emergency operation plan. One is a patient circuit. So following the patient from admission to discharge, exactly where is that patient going to go? How are they going to get treated? Very often this could be the same way it is in your day-to-day clinical practice, but often it's not. So, for example, when you get a surge of patients and there's too many patients to be taken care of in the usual accident and emergency department, you may devote another area, an office, a cafeteria, a waiting room, to deliver patient care as well. So you may decide to take the less injured patients and create a unit in the cafeteria, for example, and have them evaluated there. So that's why it's important to create a patient circuit for the emergency operation plan, so you can adapt to all of those ways that your disaster response is different from your day-to-day operations. You should also have an area about human resources. What's the organizational chart for the structure? Who's going to run the alternate care area? Who's going to run triage? Who's in charge of the whole response? It may be the head of the hospital. It may not be. Or what if that head of the hospital was away when the disaster struck? Who's going to fill in that leadership position? Those kinds of things. The human resources should also include a call list. How do we get our employees who are off shift and call them up and ask them to come into work if necessary, if you need additional staffing, that kind of thing. Procedures and tools for case management, standard protocols that are clear and specific. Forms, if you're going to use disaster triage tags, I'll talk about that. Other patient care forms if they differ from the way you operate normally. You have to address logistical issues in your emergency operations plan, specific materials for each department, how you're going to resupply the supplies that you're using, those kinds of things. Infection hygiene, we call infection control in the United States. It's important to address that through this whole plan. Where you're going to get food and water for your staff if they're going to stay long hours and you're going to feed them while they're working. All these things need to be addressed. coordination in how that happens, not just within your system internally, but also externally. You need to define, again, those partnerships and how you're going to coordinate with pre-hospital care, with the suppliers, your medical suppliers who might bring in food for the hospital staff and patients, those kinds of things. Also, you need to address security. As you saw in that video, it's really very important to control your entrances, both for safety and security of the staff, but also for the patient's sake. If you have a room crowded like that with people, how are you going to be able to deliver care? So being able to post a sentry, it may be common practice under normal conditions to allow all the family members in an exam room with a patient, but when you have so many patients and so much crowding, you really have to create different rules around that. Normally, we allow one family member in with a patient, but if things are very busy in our emergency departments, we actually have all family members and friends wait out in the waiting room. So creating security to make that plan is important. Psychosocial support for family members, patients, and staff, how you're going to make that happen. And then once you have your plan, as I said before, you need to practice your plan and make sure it's an effective plan. I always teach having a plan is not the same as being able to implement it successfully. And I'll give a couple of stories that illustrate that point that are examples of this. This picture is an aerial picture from my response to New Orleans for Hurricane Katrina. Hurricane Katrina hit the United States 8 months after the tsunami affected this area, and it was in August of 2005. And it was such a strong hurricane. The winds weren't so strong, but the surge from the sea was quite strong. And New Orleans is a city in the United States which actually exists mostly below sea level. And over the years, they've built up levees to protect it against the seawalls and against the canals and things like that that drain into the sea. And what happened is with the storm surge that came in with the hurricane, it broke those levees and the city flooded. So there was some damage, wind damage from the hurricane. It took out power and everything. But the biggest problem is that the city, within about 8 hours, flooded. And it's the first time in U.S. history that we had to evacuate a city of 500,000 people. So every citizen had to leave the city. So these buses were the buses that were intended. The city of of New Orleans has a fair amount of poverty, and so over half the citizens don't have their own car, their own vehicle, their own way to get out of the city. So the plan for the city included these school buses. School buses in the U.S. are yellow, and these were the buses that were intended to take the citizens of New Orleans out of New Orleans in case the city had to be evacuated. The problem with that plan was they never identified drivers for these buses. So when the need to evacuate the city came along, everyone was clearing out. They had nobody who could or would drive these buses, and they essentially sat unused. And all of the people that couldn't get out of the city had to gather in a football stadium. And it was a terrible mess, and it took days to get everybody out adequately. And so I bring this up because that's an example of the city had a plan to evacuate people, but they never tested the plan. They never realized there was a flaw in the plan. And so as good as you may be at having all your committee members sit together and create a plan, and you don't really know if it's going to work until you test it. Another example also came out of the event in New Orleans. Memorial Hospital, all the hospitals in New Orleans that got flooded had to evacuate. And one of them was Memorial Hospital. And in their HVA, in their hazard vulnerability assessment, they determined that flooding was one of their top 3 risks, right? So they knew that flooding was a potential problem. Their plan to evacuate the hospital had plans to take people out by ground vehicle, by trucks and vans and buses and ambulances. So, in retrospect, that doesn't make a lot of sense because if one of your risks is flooding, how are you going to drive people away if your place is now flooded? And so what ended up happening at Memorial is that they were not able to evacuate before the flooding came because it came very quickly. Now they have a need to evacuate, and their plan doesn't work because they're going to do it by ground, and there was no way to do it by ground. So they also had to wait 6 days before they finally had enough help from outside, people in boats, helicopters, other things to help evacuate the victims. So without testing your plan, it could just be a lot of wasted paper sitting on a shelf. It could not be an effective plan. So that's one of the key reasons that we need to test our emergency operations plan and do disaster drills. Another one of the requirements from Joint Commission to get accreditation of hospitals in the U.S. is that every hospital has to do at a minimum of 2 disaster drills every year. And so we'll test something different every time. So let me go on to talk about the disaster plan for the accident and emergency department specifically. And we'll go through this talking mostly about the chain of casualty care and how that has to happen. This is a picture from my response to the post-election violence in Kenya in 2008. So really the chain of casualty care is the path followed by casualty from the point of injury all the way to specialized care as the condition may dictate. And these are the key areas: the pre-hospital care, what happens in the accident emergency department, and then what happens through the hospitalization and to a specialty center if needed. And again, your plan should include all of that. We'll focus on the accident and emergency care department. This is the clinic area that we built up I did a response with Doctors Without Borders to Kenya during the post-election violence in 2008. And we created a trauma clinic next to one of the slums where most of the violence was happening. And the local ambulance system essentially stopped functioning because the feuding tribes were not really respectful of the EMS system. So even if you were a health worker, an ambulance worker, if you were from the opposing tribe, they would pull you out of the ambulance, beat you up, and set fire to the ambulance. So the local EMS system stopped working. The MSF staff had to start using our vehicle to go out and get patients and bring them to the clinic. And this was the clinic that we set up where we would do trauma care, and then anyone who needed a higher resource than we were able to do, we could drive or ship to the area hospitals to take care of it. And so again, patient circuit became important in developing the whole flow. So this is an example of another Doctors Without Borders patient circuit in an emergency department that was set up in Iraq. And the point to illustrate here is that you really have a map of your facility and you see where do patients come in, where do I set the security guard to control access to the department. You can see on the top right there's a resuscitation room. A little below that is the waiting room. And then different areas of this accident and emergency department are designated for different triage levels, and I'll go through the triage levels in a minute. The red and the yellow are the most immediate. The black are the expected to die, and the green are the less injured. So we created areas of different places that you send patients, and that helps you organize how you deliver care in your emergency department. So again, part of the patient circuit, the patient arrives to the hospital, and the first step that happens is triage. And depending on the different triage levels, different things happen to the patients. They go to different places. So the patient circuit has to consider triage, the stabilization and initial care, moving forward if they need surgery or hospitalization is needed, and then ultimately discharge of that patient, how that happens to another facility for additional care or home once you've delivered definitive treatment. These statistics are from the Red Cross. And in a war situation or trauma situation, civil unrest, if you took 100 victims, approximately 75% are in that green category. They have injuries that need attention, but they can wait for some time. They're not immediate. About 20% are usually lethally wounded and will likely die, and about 5% need emergency care. So when you get all these patients all at once, the really key things about dealing with this effectively, saving the most lives, is you want to detect that 5% that need emergency care right away and get that care to them as quickly as you can. And then you want to take the other 75% that need treatment and give them the correct treatment in a timely manner and deal with it effectively. So when you get those 20 victims from the bus accident, or 40 victims from two buses colliding together, or 100 victims in a war situation, all of this begins with triage. And to classify the wounded according to simple criteria, and then you can categorize them and who needs the care most efficiently. Triage, as you probably know, it's a French word. The whole concept of triage came from the Napoleonic Wars, when a war surgeon realized that he was getting too many wounded to take care of them all in sequence. So he developed the concept of prioritizing the most immediate first. So general priorities, obviously, respect the triage system, follow it. It will help you identify the sickest. It'll help you save the most lives. In that chaos of the video where you saw when the initial victims come in, there are non-medical priorities too, which includes the crowd control, the security, the infection control. All that needs to be in your policies and your plans. So in disaster situations, the triage is different or should be different than the normal triage that we may do in everyday life in accident and emergency. Because even in a busy day in accident and emergency, maybe you get an average of one patient every 5 or 10 minutes. You can have a nurse or two at 2 different triage stations. You can take 15 minutes to do vital signs, to prioritize that patient that way. But in a disaster situation, you literally may get 20 patients at once or 40 patients at once. And so you can't take 15 minutes to triage one patient at a time, because by the time you get to the 48th or 49th victim, it's 4 hours later and you're still triaging. So disaster triage has to happen more quickly, and there are several ways to do that. So the idea of disaster triage is to really rapidly evaluate everybody in 1 or 2 minutes. You deliver minimal treatment, not necessarily just no treatment. You do just basically life-saving interventions, and you move on to the next person you categorize. So there are several systems of disaster triage. This is one of them that has come out more recently, and this was created by a panel of 50 experts internationally, and it's called SALT, Mass Casualty Triage. SALT stands for sort, assess, L is for life-saving intervention, and T is for treatment. So first you sort, then you assess, you deliver quick life-saving interventions for those who need it, and then the fourth you get to definitive treatment. So I want to walk you through it just so you get a sense of what this could be like when you work in an accident and emergency department. So the first step is sorting. And paramedics and firefighters do this all the time when they come on scene of a multi-car accident or a bus accident or something. But sometimes you'll get 2 vans of victims unloaded and no one's done anything yet, and you have to do that in accident emergency. So the first thing you do to do global sorting is you just speak up and say, anyone who can walk, get up and go over here. So right away, you've sorted a group of patients who are conscious enough to be able to process instructions and follow commands, and they're well enough to get up and walk. So they at least have a blood pressure of 90, right? So you've sorted right there the least acute. So those are the people that you're going to look at last. And then let's say you had a group of 50 people, and 30 of them got up and came over here. So you have 20 that are still lying on the ground, like in that video that you saw. And then you say, well, if you didn't walk over there, who can wave to me? Show me that you can hear me. And then of the 20 that are there, say 10 or 15 kind of wave to you or say something to you. You say they're signs of life, right? Maybe they didn't get up because they have a broken leg or something. So you don't know exactly why they haven't walked over, but at least they're responding to you. So those people have some kind of sign of life. They've heard you say, wave at me. They've responded. And then the third group of people are those that are still and haven't moved. Maybe you even wonder if they're alive. So you've just, in about 30 seconds, done a global sorting of 40 people, right? Those that can walk and move and listen, those that are showing signs of life and waving at you, and the 5 or so that aren't moving at all. So now you start to assess them individually, and you start with the group that didn't move at all, because they're likely going to be the most sickest. So that's the step 2. Then you assess them, and you walk over to those people that aren't moving, and you do that quick ABC again, right? So, and that's when you also implement life-saving interventions. So you look if they're breathing, you check if they have a pulse, do they have any obvious injuries, and that's when you can take 30 seconds to do these top 3 life-saving interventions. You probably can't read them in the back of the room, but you see that cross, that black cross there says LSI, life-saving interventions. 1, control major hemorrhage. 2, open an airway for someone that's not breathing. And 3, do a chest decompression for someone who might have signs of a tension pneumothorax. Those are the 3 life-saving interventions you can do quickly before you move on to the next person. And that alone might save a life right there. So if you have somebody who's on the ground who's obviously has an arterial hemorrhage, start wrapping that up. Put pressure on it, get an aid or something like that. Controlling hemorrhage. Remember, as we've talked about since yesterday, controlling hemorrhage is the number one preventable cause of death after an injury. So if you can start controlling major hemorrhage, you've done something for that person. You assort him to an area, that these colors that I'll talk about, and then you move on to the next patient. For someone who's not breathing, again, maybe they're hypotensive and falling unconscious, and maybe it's just their tongue has obstructed their airway. So can you reposition them quickly, try and do a chin lift, open their airway. If they start breathing, that person has signs of life, he can be triaged to an immediate category, a red category, but before you move on to someone else, and then he needs to get seen right away. If that person is not breathing, they're done. In this setting where you have 50 people and you're trying to save the most lives possible, you probably don't have the resources, the ventilator, you would have to spend 2 or 3 or 4 people on intubating that person who's showing no signs of life, and meanwhile you may have several people with arterial hemorrhages who you could save, and now you won't get to them because you're spending so many resources on that one person. So in a true disaster situation, if someone's not breathing on their own, they get categorized to the black category. So then you move on. If they're breathing on their own, then you go over to that next big box. Are they obeying commands and have purposeful movements? Do they have a peripheral pulse? Are they in respiratory distress? Is the major bleeding controlled? So if you go no on any of those, you'll go to either an immediate category or an expectant category. And as you look down there, it says likely to survive given current resources. So for example, let's say you have someone with evisceration of abdominal contents, like in the last lecture we saw somebody who came in like that. Let's say what came in was 6 or 8 victims, and you're in this teaching hospital, right? So 6 or 8 victims is not terrible for a facility this size. How many doctors and nurses do we have working in this facility? So that person with the eviscerated abdomen, we can probably take care of all of those 6 or prioritize them. That person with the eviscerated abdomen would go into an immediate category. And it would be an appropriate triage decision to devote the resources, get the trauma surgeon, prepare the OT, and get that person up for definitive care. If you have the same 6 or 8 victims delivered to a small rural hospital that has a general practitioner, no surgeon, and the anesthesiologist is 2 hours away, there's a small OT, and you have this same victim who has an eviscerated abdomen, but you have other people, say, with orthopedic trauma or other kinds of things that you can also save their life. It may be that in that situation, the person with the eviscerated abdomen may move to an expectant category. Maybe you hope that you can get other resources, transfer him to another facility, call the surgeon and anesthesiologist. Maybe they can get in more quickly than the 2 hours. But with the resources you have available at that moment, you're probably not going to be able to save that person. That person would be categorized to a black category, if that makes sense. So given current resources, you can triage patients to different categories. Okay? And then going back up to the big box with those questions, if they don't have any of those things, then they can move over and they can go to a delayed or a minimal category and get seen later. So just to present briefly to you, the concept of disaster triage is different than the way you triage on a day-to-day basis in your hospital or clinic system. And I just went through it briefly in about 5 minutes. That's not enough time to make you experts on this. And if you get involved with disaster drills or plans, this is something that potentially should be practiced. As a matter of fact, this is actually one of the disaster drills that we run at our hospitals many times. We say today's drill is just on triage. And we actually we moulage victims. We get students, medical students, student nurses many times, and they become our victims. And they each get a little card about who they are and what their trauma is and how they should respond to the student who's surveying them. And so then we'll put them in a room, and sometimes we'll put fake blood, or we'll splint a limb for someone who came in with a fracture, those kinds of things. And we have our students practice this. So everything I told you, we set them in the room, and they start sorting. And certain of the victims know they're supposed to go over and stand. So they're not really traumatized. They're moulage victims. And they go through that practice. because the only way to get good at doing this is by practicing it. And our firefighters and paramedics are very good at doing this because they already do this in the field in their regular practice every day, as I said, when they come across motor vehicle accidents and things like that. But healthcare people are rarely good at doing this because they don't practice it. In most situations, we don't have to move to a disaster triage mode. And so this is a good thing to drill on and get good at for the staff in the accident and emergency department. Okay, so again, highlights about triage. You should classify according to simple criteria. It gives you a vital prognosis for the patient and what category they go into. It can quickly identify who needs to go to the operating theater and who needs to go more quickly than someone else. The basic categories here are the reds are the good chance of survival if you have immediate interventions and treatment. Yellows, intervention required, but less urgent than the red group. The green patients are the ones that need some intervention, but they can wait up to hours. I mean, someone who has a laceration that needs to be repaired, but it's not arterial bleeding, it doesn't compromise neurologic structures or joints, that can get cleaned up, that can wait hours to get evaluated. And then the last category is the black category or gray category in some areas, and those are it's too late to save those lives, and they need some comfort care. So types of things that we see that we triage into each category. A red category would be something like moderate to severe respiratory distress, acute hemorrhagic shock, abdominal or thoracic wounds with abnormal vital signs, incomplete amputations, or vascular wounds with ischemia to the limb distally, burns, second and third degree burns, more than 15 to 40% of body surface area. A yellow category is slightly less urgent than the red. Those would be things like stable abdominal wounds without signs of shock, wounds with tissue loss requiring debridement, maxillofacial wounds without respiratory distress or difficulty, fractures and vascular wounds without ischemia, and wounds to the vertebral column with or without paralysis. The green category are the minor wounds, burns to less than 15% body surface area, sprains, other kinds of minor injuries, psychological trauma. And then the black category are the seriously wounded that have a slim to no chance of survival with your current resources at the time, depending on the facility you are. Examples are major body surface area burns, unconscious cranial trauma, CNS trauma. This is an example of a triage tag. So remember the disaster triage process I told you. How do you document or pass along or leave a record of what you've done in that 30 seconds or 60 seconds that you were by that patient? So each patient gets a card. You can have a nurse or scribe, someone follow you, or more junior staff member that can fill in some of the key information here. You can see the big R, which is the triage category. It tells everyone who comes after you that person has already been triaged and what their category is. There are many versions of this. You just need to create one and exercise with it and decide what kinds of information go into it. So let me talk a little bit about the process now. In about 15 minutes, 10 minutes, 12 minutes, I've started to triage my 40 victims, right? And the other staff here are now, they came in, and everyone that's red and yellow, someone might be directing the greens to go to some back room, cafeteria, we'll get to you soon. The other clinical staff are grabbing the reds and yellows and moving them into the treatment areas where the reds and the yellows are going to get seen, and staff are dedicated to starting treatment on those as you finish triaging your 40 victims. And so additional staff are then taking care of people in the red treatment area. So this is where the organizational chart may be of value, right, or is of value, but that I may have the role that day to do the disaster triage. Dr. Leonard may be assigned to take care of the red treatment area. Dr. Nihal may be assigned to take care of the yellow treatment area. So everyone has a role. And you go, same thing. You divide up your nursing staff that way. You divide up all the technicians and the help that way. So the kinds of things that we do for the red and yellow patients, again, this is the same thing that we discussed yesterday. You go through the A, B, C, D, E, don't forget your camera, of trauma care and ATLS. And you re-examine these patients from head to toe. You give them IVs as necessary. Antibiotics per your protocols. Many of open wounds are contaminated, infected. Antibiotics should be part of a protocol with that. Your surgeons should be involved with creating the trauma care protocols that happen even in accident and emergency, obviously. So you may need to give them antibiotics. You may need to update tetanus status, appropriate labs and x-rays as are indicated by your primary and secondary review, those kinds of things. Be careful. Don't suture. Many wound injuries are contaminated, have devitalized tissues. You need good input about what to stitch and what to close and what can wait for definitive closure. Immobilize and splint fractures, especially if they're not going to get treatment right away. You don't want to. It helps alleviate pain. You don't want to worsen a fracture. You don't want to create vascular compromise by leaving a fractured limb unsplinted. Put patients in position of comfort. Check the patient's status over and over. And patients can get recategorized and retreated. Someone that was in the yellow category and didn't seem that bad initially can fall into worse respiratory distress and maybe needs to get moved up to the red category, for example. Or you can have somebody with a deformed ankle fracture and no dorsal pedal or tibial pulses, and he has ischemia to the foot, and he's in a red category, and then the clinician might quickly, say grab the sides of the bed and just pull on the ankle, improve the deformity. It's still a broken ankle, but now it's anatomically aligned and your pulse is returned. That patient can drop from a red category to a yellow category. You splint the ankle and he can get his surgical repair of that broken ankle later on. So you can recategorize people as the need arises. So the types of things that are surgical priorities in this would be thoracic trauma with respiratory distress, maxillofacial wounds with respiratory distress, significant external hemorrhage, especially if you're still having difficulty controlling it, penetrating abdominal trauma, especially from high-velocity injuries. You need to explore all gunshots and penetrating trauma from explosions. Not all stab wounds may need to be explored. The surgeon should make that call. Unstable, non-penetrating injuries, also surgical priority. Lesions of the limbs with amputation or vascular compromise distally, and burns from 30 to 50%. Okay, some issues about care for patients that are in the green category, the less injured patient. Obviously, that person still needs a head-to-toe exam. Sometimes you'll find a concerning injury that wasn't apparent because they look well. Monitor vital signs, give tetanus, appropriate legs and x-ray, the same kind of thing, and treat wounds, minor wounds and burns. On this slide, I have the fill in the patient's file or medical record. I didn't say that for the others, but in addition to the triage tag, it is really important, especially if you are reminded of the chaos you saw in that first video, very important that you have a patient record of treatments, evaluations, interventions. It could be the chart you normally use if you find it's effective in this kind of setting. You may want a specific one-page document that has room for the orders, nursing notes, physician notes as well, something that can stay with the patient so that future care teams, as you move them to different locations in the facility or in the hospital, will know exactly what was done. So maintaining documentation is very important in disasters. It's something that when you see the chaos of that video, it's something that we as healthcare providers tend to leave behind or forget in disasters, but it's very helpful for the patient care and future medical care that stuff gets documented. So just because someone's been categorized to a black category, an expectant category, expected to die, doesn't mean that we ignore them or neglect them or the family. These people may still be alive. They may have devastating brain injury, but they're still breathing. But they're still alive, and we still need to treat them and their families humanely. It's very important to give them adequate analgesia, and it's very important to provide psychological support. If you have clergy, if you have social workers, if you have psychology, psychiatry staff, they should come in and help care, certainly for these patients and these family members. So a couple of general points. All patients, even the minor ones, have been victims of a traumatic experience and need care, and especially psychosocial care. And don't forget to treat pain issues. So a couple of things that don't pertain to accident and emergency, but if we work in accident and emergency, we're going to be moving patients along into the operating theater or hospitalizing them for further care, and we need to be aware of some of the things that are important in that setting. The quality of primary surgery really determines the final result. So our surgeons should not be quick or sloppy. They need to be efficient. They need to stabilize, but they really need to do quality primary surgery from the beginning. Intervention priorities have to be constantly reviewed. So again, if someone deteriorates, their triage category needs to get changed, or the other way around. If someone improves and stabilizes, they can get moved to a less acute category. Hospitalization, we need to have particular attention to the postoperative care, nutrition, psychosocial support, and physiotherapy as needed by patients. The psychological support, again, I can't say how important it is to do this from the very beginning, and not just for the family and for the victims, but also for the staff. And it's important also to not wait until the event is fully over, because frequently these events are traumatic not just for the patients and the staff, but it's very difficult for us as caring people and healthcare workers to see the devastation and the suffering that goes on. And so to have psychosocial support when available for our staff members is very important as well. So a couple of points before I wrap up to talk about the discharge from the emergency department, and that could be either discharge to home or discharge to the hospital or another referral center. If we were able to provide definitive care, then that patient can be discharged home, assuming that the environment is safe to do so. In civil unrest situations, sometimes hospitals become places that patients and families seek shelter from further danger. And so that actually should be and could be in an emergency operation plan for a facility. Where do we accommodate patients and family members that can't go home? If the patient needs specific care that you don't have, you need to refer to another facility. So it's important to assess what are the capabilities of your facility. This medical center, for example, is a tertiary referral center. Their plan about transfer and referrals has to include who are the community hospitals and clinics who are going to be sending us patients here, and how do we prepare for that? Whereas at those smaller clinics or hospitals, you have to say, well, we don't have a neurosurgeon, so if we have someone with a treatable neurosurgical case, where are we going to send them? Do we have an agreement in place with that hospital? We don't have dialysis here. We have patients with renal failure. Where are we going to send people for dialysis? What medical center? Those kinds of things. So in advance, in your emergency operation plan, identify the kinds of services you can't provide and identify where you're going to do that in advance. So when the need comes in a disaster, you have those agreements in place. You can pick up the phone and place the call, and that will improve the likelihood that you'll be able to effectively transfer somebody for definitive care. So the referral criteria depend on a number of things. Obviously, as I mentioned, the specific need of the patient and also the stability for transfer. So you may have someone that needs neurosurgical care, but they're so unstable because they're about to herniate that they're likely not going to survive the transport. So maybe that patient should just be treated expectantly at your facility as opposed to transferred. So someone needs to be stable enough to survive the transfer. You shouldn't just send them because you can't take care of them. What's the availability of specialty care, and can those facilities take them? Because maybe in a very big disaster, this hospital may be overwhelmed as well. And so you need to establish that call first and say, can you handle this patient? I need to send you. That's part of what the agreement is and how the communication should happen between facilities. It's also important to have the appropriate referral documentation, send the important medical record and the assessment and treatment that you did at your facility so that the receiving facility has that information to help them in patient care. And then whenever you can, after everything is over in the recovery phase, it would be wonderful to do follow-up on the patients you referred and the patients you treated and sent home. So in summary, I want to mention the things that I've discussed here. The first summary is be aware of the cycle of response after an event and how brief it is, and how we spend most of our time in recovery, mitigation, and preparedness. And how effectively we are in our response phase is totally determined by how good the work was and how much work we did in the preparation phase and the mitigation phase. Emergency management is a complex process. It operates at an international level, national level, local communities, healthcare facilities, and even at an individual level. I frequently train the first part of disaster preparedness is personal preparedness. What's your plan? How are you going to take care of your family so you can go to work, if you have something? How are you going to identify where your family is so you're not so worried about them, you feel like you have to leave work to go help them? If you have a personal plan, that's very important. Then you can participate in whatever's going on at your work site, or clinic, hospital, that kind of thing. So emergency management, complex, and it's at all levels of society and all critical infrastructure industries, not just healthcare. Healthcare emergency management, identify a leader, have a committee, a disaster committee with involvement from all the relevant stakeholders, all the players involved. Make a plan, a disaster plan or an emergency operation plan. Practice that plan. You have to make sure it will be an effective plan that when you implement it will actually work. And disaster drills are very important, not just to guarantee the validity of your plan, but also to train your staff. And then specifically in the accident and emergency department, define the patient circuit. You do a disaster triage, and then through ATLS, ABCD, treatment care, stabilization, definitive care, follow your treatment protocols, make sure you provide psychological support for patients, family, and staff. Thank you very much. Any questions? I failed yesterday, actually, after my lecture to ask, and I should have. And does anybody have questions about this or what I spoke about yesterday? Thank you.